Dr. Dr. Classen is a renowned expert in patient research, safety research, and patient safety programs. He serves on several advisory boards and is just an amazing person and a human. We're glad that you're here with us today, and we'll turn it over to you, Dr. Classen.
Great, thanks very much. Get started here. So I'm a faculty member at the U, but I also work part-time for a startup, and that startup is called Pascal Metrics. And I'm going to share with you how artificial intelligence and health information technology are transforming how we manage the safety of care in the United States. As you're probably aware, if you go to the hospital, there's a famous line, get out of the hospital quickly before it injures you. And that's not a minor issue for most patients. Indeed, the latest research shows that if you enter the hospital, 1 in 4 patients will be injured as a part of their hospital care. And that was a study published last year from 11 Harvard teaching hospitals. They found that 1 in 4 patients got injured, had a safety problem as a part of their care. And these are some of the very best hospitals in the United States. And I think the feeling is if 1 in 4 gets injured in Harvard teaching hospitals, it's probably a lot higher in the United States. And indeed, there are other studies to suggest that as many as 1 in 3 patients can get injured as a part of their hospital care. In addition, those researchers also looked in the outpatient setting and then found that about 7% of outpatients experience injury related to their care every year. So another group at Hopkins suggested that as many as 1 million patients every year get injured from misdiagnosis. So when you roll it all together, we're probably injuring millions of people every year in the United States. And one study suggested that safety problems are the third leading cause of death for hospital patients in the United States. So this is a really huge problem. And we really haven't done a good job solving this problem despite focusing on it since 1999. In 1999, a famous group, the Institute of Medicine, published a report that basically said we killed two 7047 full patients. If you imagine two 747s crashing every day and killing everyone on them, that's how many people we kill in healthcare through safety problems. And it doesn't look like we've gotten better. It looks like we've actually gotten worse. So I'm going to talk about how this problem is being solved with health information technology and artificial intelligence. I know some of you are going to screen a movie on patient safety and artificial intelligence. What I'm going to talk about will be the next version of that movie. That movie just talks about what's possible. I'm going to tell you what's actually being done now to solve this problem. Aviation has done this for years. Back when they developed the 777, Boeing developed the capability of having real-time safety surveillance of every flight, every minute. And that capability, initially in the 777s, is now working on every airplane, almost every airplane in the air. So when you're flying on a plane, safety information streams out of that plane on a minute-by-minute basis, and somebody at an airline operations center is watching. And my nephew flies for Delta, and he landed his plane in Atlanta, and everything went fine. And after the passengers got on the plane, a Delta representative walked on the plane and said, "We're taking this plane out of service." And my nephew, who's a pilot, said, "Why?" I didn't say anything wrong. He said, "Because we monitor all these parameters, safety parameters of your plane every minute, and we saw the brakes started to overheat slightly on landing. Not hot enough to tell you, but hot enough for us to take the plane out of service and into maintenance." So this type of real-time safety monitoring has been going on planes for 2 decades, and now it's pretty much universal. So the question is, can we do this in healthcare? And the answer is yes. So technology has been developed to watch every patient every day in a hospital every minute to see how they're doing from a safety perspective. And someone from an operations center is looking at these patients and seeing, just like with a plane, if anything's going wrong or about to go wrong. and they can intervene and save the patient. So that's what we're going to talk about today and how we built the technology to actually do that. Don Berwick is a famous guy who's been knighted, among other things, but was the head of CMS for a long time. And he and I wrote a paper saying that after we put all this money into electronic health records, which we did with the HITECH Act, why aren't we using that real-time information to emulate what the airlines are doing? Real-time safety monitoring of patients, just like the airlines do. We have that technical capability. And indeed, after we put the electronic health record systems in, we've gotten to about a 95% adoption rate at hospitals. And guess what? We've demonstrated with all the leading EHR vendors, you can actually replicate what happens with the airline monitoring systems in human monitoring systems, in patient monitoring systems. And so our call here was for hospitals to move down this road rapidly, to start building, if you will, versions of airline operation centers that can monitor the safety of care down to the minute in hospital patients, which obviously, if we're injuring 1 out of every 4, we need to do. So we actually published a paper back in 2018 from the company I work at part-time called Pascal Metrics, where we actually developed this airline type safety monitoring system that could monitor every patient every minute in a hospital bed, and implemented it in all the leading EHR vendors, and found that you could detect a whole lot more problems with this approach than with the antiquated approach we use in most hospitals, which relies on after the fact incident reporting systems. Indeed, what we found is when you compared how much safety problems we found with this prospective electronic surveillance system in hospital inpatients versus how much of this stuff that was detected by incident reporting, we found 50 to 150 times more safety problems with this electronic surveillance, much like the airlines did when they automated this within the Boeing 777 and all of their programs. And we did this through a patient safety organization, the one I work part-time for, and it allowed us to begin to track safety problems in real time at all levels. We could track it at the patient level, and we'll talk about that at the end. We could track it at the individual physician or nurse level. We could track it at the hospital quality improvement level. We could even track it across a whole big health system with hundreds of hospitals. So the technological capabilities to do this have already been developed and are in operation in more than 100 different hospitals in the United States. And basically, the way this works is real-time data is streamed out of the electronic health record into the company I work for, and then a variety of algorithms are applied to that information to detect patients with problems, safety problems in real time, and allow for that information to be documented and validated, and then allowing for concurrent intervention. So helping patients while they're experiencing their safety problem in the hospital bed. Because usually with our incident-based reporting systems, manual, we don't find out about this particular problem until long after the patient's gone. You either left the hospital or succumbed to their illness. So this is a whole new way of thinking and emulates the airline example of real-time safety monitoring. And one of the big challenges that AI solved was that when you start looking for these signals of safety problems in electronic health records, you're overwhelmed with unbelievable amount of noise. And many organizations that have tried to do this, whether hospitals or vendors or others, get stopped right here. They detect so much noise they can't find, if you will, the needle in the haystack. And organizations get so overwhelmed with all the noise that they can't make these real-time safety systems work. Well, the airlines develop, if you will, filters to filter out a lot of this noise and only find the real safety problems. And that's essentially what Pascal Metrics has done, using both domain expertise, but also artificial intelligent algorithms to sort out the needle in the haystack, if you will, and allow us to focus on only those safety problems in real time that are real, and not get caught up with all the noise. And so artificial intelligence was a critical way to separate through all this noise and come up with a small number of really serious safety problems that could be not only addressed in real time, but documented, leading to quality improvement opportunities. Here's just an example. When you look at these automated systems versus the manual incident-based reporting systems, the manual incident-based reporting system in this study detected 147 safety problems, adverse events we call them. The automated surveillance, same patient population, 3,740. So this is a real transformation of how we do safety. Here, voluntary reporting after the episode's over and you can't help the patient. Here, automated detection that finds the problem in real time when you can actually help the patient. So a real transformation of safety, and anywhere from 25 to 100-fold difference between how many safety problems you find out about. Allowing this type of real-time safety system has led to the biggest improvement in safety problems in hospitals ever recorded, as high as a 70% reduction in the occurrence of safety problems in hospital patients with this type of real-time safety monitoring system, which is akin to what the airlines found when they put these real-time safety problem detection systems. But what the airlines found, which we're also finding in healthcare, is not only do you decrease the safety problems, but it leads to a lot of operational efficiencies and improvements. And there's a new study coming that's going to suggest that safety problems in the US healthcare system, when you look at them in total, inpatient, outpatient, look at risk management, return to work, delayed return to work, outpatient costs, may add up to $1 trillion every year. $1 trillion in terms of waste. Because when you experience a safety problem in a hospital, we used to think it stopped there. Now we know, based on a study at a large HMO, those safety problems haunt you for a year after you leave the hospital, with increased risk of readmission to the hospital, increased risk of death, not only at 30 days, but for up to a year after the hospital, and a dramatic increase use in outpatient interventions needed to deal with the down the stream complications from your in-hospital safety event. What's an example of such an in-hospital safety event? They anticoagulated your blood, made it too thin, and you had a bad bleed in the hospital. That problem haunts you for a year after the hospital with significant excess costs. So that's why this area is so ripe for help from AI, because not only can you detect them in real time, you can actually predict them before they occur. And this is the same company developed basically a machine learning based algorithm that could predict patients developing safety problems up to 3 days before they occurred. This is a patient, a real patient. All the numbers are mixed up, so you can't tell who and when and where, but came into the hospital with a surgical emergency, underwent a appendectomy, and this is their safety predictive score, the score that would predict the occurrence of a safety problem. It was high when they came in with their appendicitis. It got low after the surgery to remove the appendix, and then the patient was in the hospital for several days and it started to go up again. And if you clicked on any of these dots, you could see at that time what were the drivers of the risk of developing a safety problem. So if you click on this dot as the safety score, predictive scores beginning to go up, you can see that their hematocrits low, they've had a number of surgeries, their white counts elevated, their platelet counts really elevated. And as a clinician, when I look at that, I would say, oh, they're having a problem related to their surgery. And indeed, that's what happened here. Right here, the patient went on to experience a safety problem. They had an intra-abdominal bleed. And then right here, they went on to develop an intra-abdominal abscess. And so this system actually predicted it more than 72 hours before it occurred. And that is where we're headed in safety, which is not only real-time monitoring, but real-time prediction. You know, you came in for this surgery, you did well initially, but in 2 or 3 days, you're probably going to develop this complication. We can do that now with artificial intelligence. That changes the whole game in safety and allows us to get to zero harm, i.e., we can predict problems long before they occur, intervene, and stop them from occurring. Now, just sharing this with healthcare workers is not enough. This was a Robert Wood Johnson project that funded us here at the University of Utah to take what you just saw and share that information real time with patients and their families. Traditionally, we don't do that. We only share it with the healthcare workers. And if a problem develops in the hospital, the patient may not find out about it until late in the hospitalization or not until after they leave. This was the idea is why don't we just share all this information in real time with patients and their families? And that's basically what we did here. We created a patient safety dashboard designed by patients and families that they could look at on any device, on a desktop, a laptop, an iPad, even their iPhone. And it would show them an overall risk score. How am I doing? And if my score is going up, what should I be concerned about? So they could click on any of these dots and be told in real time, these are safety risks or problems you have. So if they clicked on this dot, it would say, you've tested positive for a bacteria in your urine, and that could give you a very bad infection. Here are questions you can ask your care team about this particular problem. Here are things you can do to ameliorate this problem. And here are things that you can learn more about this problem. And we also show another safety problem. They developed a positive test for something called C. difficile in their stool. And here are the things they could ask their healthcare worker about it. Here are the things they could do to prevent it or ameliorate it. And here's where they could get more information. So we shared all this real-time information with patients, and we shared it in all these platforms, including even their cell phone. And not only could patients look at it, but their family members could look at it both in the hospital and out of the hospital. And what did we find when we piloted this? We found that when we studied this in a hospital, turns out patients highly used it, and their families highly used it. It was not unusual to have a family member at home at night looking at this dashboard and watching over their loved one in the hospital. And in terms of outcomes, what we found is that patients who heavily used this had a lower 30-day readmission from the hospitalization they used it in and a lower 30-day mortality. So a real impact on patient outcomes if they use this particular program. And then we looked to see if it increased fear in patients. It didn't. We looked to see if patients accepted it. They did. And we did get some feedback, interestingly enough, that although we allowed them to use it on any platform, we didn't make it work on Kindle. So they wanted it on Kindle as well. So I'll finish with what does a successful AI program look like in healthcare? I think what I just showed you is one, but I want to show you one we developed here at LDA's Hospital and published in 1998 in the New England Journal. It was the first AI and healthcare program published in a big journal in the United States. And basically, this particular program led to a real improvement in how we ordered and used anti-infectives, antibiotics, antivirals, antifungals in hospitalized patients. And we studied it in the shock trauma unit at LDS Hospital. And what we found is, because at Intermountain at that time, we had our own homegrown EMR, and we had our own homegrown clinical data warehouse. So we could do things other places couldn't in terms of building an AI program that would actually diagnose, treat, and monitor patients with infectious disease problems. And we did a clinical trial of this and published this in the New England Journal showing a big improvement in patient outcomes when clinicians followed the regimen suggested by this AI program. And then here's this ugly screen back in the days when things were DOS-based, but it would pull all the information needed to manage an infectious disease problem in a hospitalized patient. And it put it in a format similar to how clinicians think about it, thought flow, we call it. And it was designed by us, who were the infectious disease service at LDS Hospital at the time, in conjunction with our practicing clinicians. So it may look complicated and dizzying, but to clinicians, this brings together everything they need to know to make a decision about infectious disease in a hospital patient. And I won't go through all this in detail, but I will just tell you that one of the most important things for any AI program to be successful is, will it save a doctor, a nurse, a pharmacist considerable time? And we actually did time and motion studies looking at this and found out the average clinician who didn't have this program spent 15 minutes collecting all the information and making a decision. The average clinician with this program spent 1 minute doing exactly that, collecting all the information, making a decision, and acting upon it. So everything in that process is in here. And I won't go into much detail, but I will just say that I'm going to make a bold statement here. Artificial intelligence programs will not succeed in healthcare until they get to this level of sophistication. Right now, they're just at simple predictive analytics. Well, we've had risk score predictions for years. Why is a new one from an AI vendor help at all uh, if it only gives me a predictive score? So I'm going to argue that most of the first generation AI vendors are going to go under. They won't succeed in healthcare because they can't address all these issues in terms of workflow and thought flow and saving time. I think the second generation will also go under. It's when we get to this, the third generation of AI programs, healthcare, I think will have success, but I think we're going to see a lot of carnage along the way. So I will stop there and take any questions that you have.
Thanks, Dr. Classen. Yeah, so if you've got questions, you can come off mute or you can put it in the chat. I just put one in there and I think you probably answered it, but as a consumer of healthcare or as a patient, anything I can do to not be one of the 1 in 4 that gets injured.
Yeah, yeah. I think bottom line now is it means you probably have to have a family member or loved one or friend in the hospital watching carefully every step of the way.
Hmm.
Hospitals have not been aggressive in adopting this for a couple reasons. First, they have the infrastructure of their existing safety, which is incident reporting after the fact. And they don't want to give up that infrastructure, even though this would work with the technology they haven't. Second, they get very nervous about legal liability if they put in these systems and find more safety problems. And third, they get worried about reputational liability if they were to put these kinds of programs in and suddenly be known for having a lot of side effects. But Medicare is going to force them to do it. We convinced Medicare about 10 years ago to move all of its safety measurement down this road, and that's where it's going. So hospitals will be dragged in this kicking and screaming. They'll eventually to adopt it. But I do think for you as a patient, having a loved one in the hospital watching everything, probably the best way to go.
Okay, until one of the Musk robots can come with me.
Until one of the Musk robots can come with you.
Okay. Alan asks about the percent of incorrect data coming out of the AI filtered data. Says sometimes you get the AI apologizing for words that have
Yeah.
multiple meanings.
Yeah, we're not using generative AI. We're using machine learning and AI we developed that was domain specific and basically um, uh, uh, led and directed by humans in the loop. So that's why we don't have to worry about that. But I do think what we did with a very domain narrow model is where we're all headed. People have tried to use generative AI to detect problems in hospital patients, and it doesn't work. And one of the reasons it doesn't work is health systems go to great lengths to take anything that could be a risk management problem out of the EHR because the EHR is discoverable. So all of what I showed you, data gets taken out of the EHR and it gets curated outside the EHR in a patient safety organization. So that prevents that data once it gets taken out of the EHR from being discovered. So all this attempt, there's a lot of stuff going on now. I'll just apply large language chat GPT-4 to my hospital EHR and see what happens. It's already been tried. It's not going to work. So if you have invested in a company like that, take your money out.
Okay, from another one here, are you seeing an uprise in AI in the telehealth contracts?
Oh yeah, absolutely. But it's not my area of expertise, so I can't really answer that for you. But yes, I mean, we're about to publish a paper on 66 of the largest health systems in the United States and their adoption of AI, not in terms of piloting, but actually implementation. And some of that will be in there. That'll probably come out in the next 2 months, if I had to guess.
Um, Dr. Richens asks about, she says, does the dashboard come up automatically or does the clinician need to look for it?
The dashboard comes up automatically in both the clinician's hands and in the patient's hands.
Cool. And then from Taylor, who are you seeing as the leaders in the market for AI in healthcare? Are there any good ones out there? Or are they all just predictive
Well,
analytics at this
pro-
point?
you know, there are all these predictive vendors that are going under right now. all they have is one predictive score, and the hospital goes, why would I pay you all this money for one predictive score, like for fall risk, when I already have a fall risk score, worked into my EHR? Why would I pay you separately and then have to have my clinicians leave my EHR and go to your test, right? And your test, even though you say it's much better than my test, when I test it in my hospital, this is what they're finding. And again, the performance in my hospital is not nearly what you, the vendor, stated it was going to be. So then the question comes up, why would I go to all this effort to pay you and then have my clinicians leave the HR and go out to you? I should do this with my HR vendor, which is exactly what's coming in the paper we're going to publish, is that most of the most successful implementations of AI have been in partnership with what we call the last mile, the EHR vendor, rather than with a standalone vendor. So there are many strikes against the standalone vendor. I think, as I said, first and second generations are all going to fail. Maybe when we get to the third generation, they might succeed. But in the paper we have coming, most of the most successful AI implementations are with the EHR vendor.
I had
Awesome.
a
Ryan, do you
question
want
about,
to go ahead?
oh, sorry, if I could jump in. The
Yeah, go for it.
adoption of the electronic health records, it sounded like you must have solved that in terms of the data must not be coming back to Pascal. Is this a layer that sits on top of the existing, like,
HL7 messages right out of the EHR.
it seems like, yeah, that is the primary barrier to all of the, all of this
Right, but
digitization and
that's we've worked
AI.
it works in every EHR vendor. We've made it work in every, it's not a problem. We can get it
That's
minute by minute.
incredible. Yeah.
Yeah, minute
I
by
could just say
minute
I
with
was an in-home
HL7.
caregiver at U of U at the Nielsen Spinal Cord. And so having lived in the hospital, been trained as an in-home caregiver, I mean, anything you could do to increase patient safety, but your remark about saving clinicians time, it was stunning to me as someone from the outside. The level of advocacy every single healthcare provider has to do, from nurse to CNA to doctor to physician, and I just started thinking, what if all this could be leveraged then to have a complete record that the patient could take to their insurance, their VA, their long-term disability, and again, reduce the time for the healthcare provider. So it sounds like an extraordinary product.
I am really optimistic about how AI is going to transform not only safety but healthcare, but it's going to take much longer. It's much like the self-driving car. All Musk and all the rest of them said, "Oh, we have self-driving cars." Well, how's that worked out? And
There's
we'll
no
get
silver bullet for this either. Yeah.
yeah, we'll get there, but it's not going to happen
Yes.
immediately. And
Exactly.
that's why I think we're going to see incredible carnage of all these pop-up whack-a-mole like AI vendors. Oh, I got a new wonderful predictive for you. Well, that doesn't
And
help
it's
me.
just an app and you can't tell what's behind it, and it
You
will not
can't
do
tell
for
what's
electronic health records.
what we call them garage vendors. They don't even have a clue about quality systems, risk management, human factors, not a clue. And yet I'm amazed at the number of health systems are willing to play ball with these guys, putting their own health IT ecosystem at risk. It's just
Oh,
unbelievable.
yeah.
It's unbelievable. And the FDA doesn't care. They just certify them on the shelf and say, "Oh, don't worry about it. Slam them in and see what happens." Well, we're going to have some big accidents.
And then you get a tech bubble around that, and what really, and then there's patience at the end of the day.
Yeah.
So yeah, I'll stop talking, but yeah, thank you.
Ryan, maybe we'll take yours as the last question. You want to come off mute and ask your question there?
Yeah, and maybe your paper, Dr. Classen, will answer this question. But where are the bright spots in healthcare, not just with patient safety, but even things like triage or diagnostics? I mean, are you seeing any of the AI companies that you think are doing a good job?
Yeah, from the paper to come, probably the most successful has been ambient AI of anything that we've seen. So I expect, when the paper comes out, that'll be one. The other area that's been quite successful is radiology. So, and by successful, I mean implemented beyond pilot, right? That's what this paper is about. We've all heard about pilots, but this paper is about what's been implemented beyond the pilot. And radiology and ambient are probably the two that have been the most successful. Many of the other things we talk about are not really working. And one of the observations in this particular study is going to be that when you ask health systems about AI applications, the most common response they say is, in terms of barriers, the AI applications are not very mature, which says that the AI vendors are not doing what's needed to convince the health systems of their value. And I can just tell you from the paper that's coming that radiology and ambient will be number 1 and number 2. And then number 3, 4, and 5 will be clinical deterioration, sepsis detection, and readmission. So.
It's great. Thanks, Dr. Classen. This has
Thank
been
you.
wonderful. Thanks everyone for joining us today at the Midday Connect. We're here every Tuesday at the same time, 11 a.m. Mountain Time. If this is your first time, you're welcome back to come anytime. You'll see an email or a text from Hannah. You can get on the list. So we'll see you all back here next week.
Thanks. Bye-bye.
And thanks, BioHive.